Sure.
I welcome you all on the ISNM MISI webinar series, and this is going to be a 45-minute talk followed by Q&A sessions, and please feel free to type in your questions in the chat box and we'll take it as they come in the order. And please mute your phones and devices during the talk. And now it's my pleasure and honor to introduce Dr. Karthik Tappa. He is a 3D printing engineer in MD Anderson Anatomic 3D Printing and Visualization Program. He's a biomedical engineer who specializes in multiple additive manufacturing technologies and has made significant contributions in the field. His research has been published in numerous leading biomedical engineering journals, showcasing his innovative approaches to personalized healthcare solutions. His work has not only expanded the theoretical understanding of 3D printing applications, but has also translated into tangible advancements in patient care. He's got a lot of knowledge and expertise and is actively engaged both with academia and industry professionals. He has collaborated on interdisciplinary projects, fostering partnership between engineering and medical communities. And he's a visionary in the field of point-of-care 3D printing. Dr. Tappa continues to explore needs and envision a future where personalized medicine is enhanced through seamless integration of engineering innovation. Without further ado, Dr. Tappa.
Thank you so much, Saima. Hello, everyone. Good morning, good afternoon, and good evening. I know you all are from different parts of the world. My name is Karthik. I like to thank Indo-American Society of Nuclear Medicine and Molecular Imaging Society of India for giving me this opportunity. I'm a biomedical engineer. I'm working as a 3D printing engineer in the MD Anderson Cancer Center. I know this is not the usual nuclear medicine or molecular imaging talk, so I'll be taking you on a ride for 1 hour, discussing all the 3D printing aspects, how 3D printing can be used in a point of care hospital settings for clinical uses. Here are my disclosure. I do not have any financial disclosure. All the views and opinions that I've been sharing today in this talk are mine and myself only. These are nowhere related to MD Anderson Cancer Center or any associated affiliated institutes. I'll be talking briefly about what 3D printing is, why we need 3D printing in point of care or hospital setting, some of the most commonly used medical applications, what's the workflow here in the MD Anderson, how do we take images and make a 3D model and how these 3D models are used, some of the challenges that we are facing and how we are trying to overcome these challenges. For those of you who know little about manufacturing, traditionally we used to manufacture objects or whatever things you need in a subtractive manner, where a big block of a material is taken and then it's either chiseled, drilled holes, or cut into pieces until the object is made, as shown in the image. So this is called a subtractive manufacturing, where you begin with a big block of material and then you keep tweaking it around until the type of object you need is made. Um, since the beginning of the 3D printing, since the invention of this 3D printer machine, the type of manufacturing process has been entirely changed. Instead of using a big chunk of material, the material is laid in layer by layer fashion on top of each other until the whole model, whatever shape you need, has been obtained. So here in this video, you can see a 3D printer printing a statue. The biggest advantage here with the additive manufacturing or 3D printing, the both terms go hand in hand, they are used as a synonym, is when you are using additive manufacturing, there is less loss of the material. So you don't have to begin with a big bulk of material and then end up having a small usable part and wasting the rest of the material. So you can use only as much as material as you want, allowing you to design and manufacture very complex and intricate design looking objects. So there are multiple types of 3D printing technologies here, and I'll be discussing about three most commonly used 3D printing technologies, and these three technologies are worldwide or within the US has been used in most of the point of care facilities. The first one, the most commonly used 3D printing technology is fused deposition modeling. Here in this video, you can see the material filaments are going all the way into the heating chamber, and the heating chamber heats up the material and lays down on top of the build platform in layer by layer fashion. So here you can see the thermoplastic materials goes into the heating chamber, and heating chamber from the nozzle, it's laying layer by layer on top of each other in a well assigned fashion until the whole object is formed. And this type of technology is called fused deposition modeling. This is one of the very inexpensive 3D printing technology. And the materials are cheap. Even the technology, the whole printers are relatively cheaper when compared to the other 3D printing technologies. Stereolithography is another most commonly available 3D printing technology. In stereolithography, instead of using a thermoplastic or a plastic filament, we use photopolymer resin. So here in this image, you can see the tank contains photopolymer liquid, which is cured or which is polymerized using a UV light. So here you can see the UV light illuminating only on particular spots where you want the object to be. So as soon as the UV light hits the UV chamber resin, the resin solidifies and converts from liquid into a solid. So as when it is making the conversion, it sticks onto the layer above it. So it keeps doing, so it keeps solidifying layer by layer until the whole model is formed. Another most commonly used technique is polyjet or inkjet. This technology is very close to the paper printing machines, except for the materials will be deposited on the platform, and UV will cure the deposited materials instantaneously. Here's a small video demonstrating how this 3D printing machine works. So you can see the print head shining light on top of the print platform, um, and a roller cleaning up the surface. These are the print nozzles where the material will be deposited from. Here you can see the material is deposited onto the build platform from the nozzles, and instantaneously a UV light is shining onto the deposited material so that it solidifies instantaneously. And again, this happens layer by layer until the whole object is formed. The only drawback with this technology is it's very, very expensive, but the amount of, but the quality of the models that you get out of this machine are unmatched. So they are of high resolution, multicolor, multi-material materials can be 3D printed using this technology. So these are the three most commonly used technologies with the additive manufacturing. Um, for, for 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 us to 3D print a object, you need to first design the object. You need to know how the shape of the object is, and you need to have this object 3D printed. So you all know commonly use SolidWorks or Fusion, Maya. These are 3D designing softwares for the automobile or animation industries. But for healthcare purposes, it's a different set of softwares that we use, and I'm going to talk more about these softwares in later slides. For a 3D 3D printer to understand a CAD model and print the exact replica of this 3D CAD model into a live object, it needs to be converted into a .stl file format. See, .stl file format is standard tessellation language format, which the 3D printer can read and understand. So when you have a CAD, computer-aided design model generated, it is converted or it is sent into a CAM software. CAM is computer-assisted machine. So CAM is the software which talks or which takes the CAD model and talks to the 3D printer, assigns the tool path, assigns the layers to the machine, and then it will dictate, hey, first layer you need to print this, and the second layer it's going to be perimeter. So CAM software which slices the CAD model and then dictates the 3D printer what it needs to do. Once the CAM software provides the instructions to the 3D printer, the 3D printer is going to 3D print and you get the object. So this is the 3D printing workflow from having a CAD model to having a handheld 3D printed model. And like I was mentioning before, SolidWorks, Fusion, Maya, those are designed for automobile industries or aeronautical industries, for animation, those kind. But for healthcare purposes, these are some of the most commonly used software which helps with the 3D printing. Of all these software, Materialize, D2P, which is also called as DICOM to print, and Osirix are three most common 510K cleared software which can be used for the 3D printing purposes. In addition to that, 3D Slicer, Invasilis, and ITK snaps are very commonly used, and most of the time these are used for the research purposes since these do not have any 510K clearance. What does this software do? What does this CAD modeling software in a medical stream help? So to have a 3D printed model, we begin with the DICOM images. We begin with the 2D images. So we take patient data, CT, MR images, and then we segment out masks. So we literally draw, hey, this is tumor, this is renal arteries, and these are bones. So once we uh, create masks for these images, we convert these softwares convert these masks into a CAD model. So here in this image, you can see renal tumor on the left side of the kidney and a CAD model generated from these images. And eventually, once you have these CAD models can be used to 3D print. And then in the rightmost image, you can see a 3D printed model of the exact image that you see in the DICOMs. So why do we need this 3D printing in a hospital setting? Imagine a surgeon walking into a OR room or walking into a clinics with a handheld model rather than having a 2D images. So most of the time, patients would not know when you're pointing out, hey, this is your pathology, this is the tumor, or this is where you have an issue. Instead of them looking at a grayscale 2D black and white images, it's always best you carry a 3D model and explain the situation where they are in, explain the pathology. Hey, this is what exactly we built the 3D model from your images, and this is the issue you have. And my approach to this issue is this. Do you have any questions? So their understanding is more. And before doing that, before even a surgeon going to an OR room, if he has a 3D printed model, he can practice on it multiple times. So there won't be any surprises in the OR, and he can go to the OR, perform the surgery, perform the procedure with high levels of confidence. And there are numerous studies which have already proven that statistically those cases or those procedures which are done without the 3D printing and with 3D printing has given more better patient outcomes, especially with reducing the OR time, reducing the amount of blood loss, increasing the confidence of the patient, and better patient outcomes. And in addition to all these, it's easy for multidisciplinary teams to intercommunicate among themselves or plan a procedure having a 3D model rather than just looking at the 2D images. So here's the brief stats that were collected in the year 2019 and 2020. In the year 2019 alone, a total of 1.65 billion revenue or billion worth value of additive manufacturing products and services have been made. And this was published in the Wohlers Report 2020. And more than 3 million patients were treated using this 3D printing technology, irrespective of cutting guides, surgical models, or even 3D printed custom implants. A total of 3 million patients have been benefited using this 3D printing technology. And this number does not include any oromaxillofacial or dental aligners, retainers. So if you also include all those, the number goes all the way up to 5 to 6 billion of patients getting help from this 3D printing. Of all the different types of applications, anatomical models, patient match devices, custom implants, prosthesis, surgical planning, these are some of the most important and commonly used applications of this 3D printing in a healthcare setting. The first application which I want to discuss is about patient education. Like I was mentioning before, walking into a patient room with just a 2D images versus a 3D images, it's always beneficial for better understanding of the patient. Once a patient understands their pathology or their situation, they can have more consent approach of what type of surgeries they can reach out to. If they have multiple options, which option to choose, which option to lose, so they can give a consent decision. They'll know their condition more. They'll at least visualize the disease size. So there was this publication we did in the year 2021 where we segregated all the breast cancer patients into two different cohorts, one who has been only shown MR images, and the other cohort where 3D printed models has been showed. And we found out from that study that all the patients who has seen a 3D model has better understanding of their condition. They can give a better consent even with their family members too. So they better understand what type of techniques they can, what type of surgery options they have, and which one better to choose than the other one. And here's a another image showing a 42-year-old female who was presented with a squamous cell carcinoma, and the tumor was in very typical location. It was originated from the trachea, and it was right between the trachea, esophagus, and aortic arch, as well as the pulmonary veins. So performing a surgery in one of these, removing the tumor resection is kind of tough, especially when all the essential organs are surrounding. You need to be extra careful, and you need to also plan this surgery way before you even enter into the OR room. And here in this image, you can see the surgeon holding the 3D printed model right exactly the location where the patient had the tumor, and explaining her condition. Hey, this is what you have, and this is what my approach is. That gives her a complete understanding of what procedures they're going to do on her and how they are trying to rectify or resect the whole tumor out. So this gives a better understanding for the patient, as well as gives total confidence to the surgeon as well. In addition to the patient education, this 3D printing is also used in the surgical planning. Here, you can see CT, axial and coronal images of a 21-year-old male who was presented with S1 osteosarcoma. Here, you can see the tumor well lit within the CT images. And once we do the CAD modeling, we sit with the surgeon who does the resection. And especially here, you can notice that the tumor has almost encapsulated the S1 nerve roots, and it's in a very peculiar location. A surgeon needs to be very careful when doing this resection, especially he doesn't want to touch any nerves or resect any nerves accidentally, and eventually that might lead to amputation of the leg, or even partial waist down paralysis. So he was very peculiar about this case, and he wanted to have exact tumor resection process, very precise cuts, so that he can take the whole tumor on block without violating any surrounding healthy tissue. So these are the cutting planes. You can look here in this video where I sat with the surgeon and placed these cutting lines, and these cutting lines will dictate him in the OR where exactly he needs to place his scalpel, where exactly he needs to do the osteotome so that the entire part of the tumor comes on block effectively. So here is a 3D CAD model with all green cutting marks shown, and here's the resections done on the day one where they were stabilizing the patient with all the orthopedic fixation devices and then doing the osteotomes. Here you can see how exactly the cuts were done when this 3D model was used in the OR. In addition to patient education and surgical planning, this 3D printing can also be used for as a cutting guides. So here you can see these 3D printed metallic or polymer cutting guides. They exactly dictates where exactly you need to place your osteotome, at what angle you need to make the cut so that you will have exact grafts. Either it might be for the mandibular reconstruction or if it is just the tumor resection. So they dictate the precise location, depth, angle of your osteotome cuts so that the tumor comes off or so that the grafts are made precisely and they fit to the grafting location accurately. So coming to the workflow of this 3D printing, how do we go from having a 2D image to a handheld 3D printed model? Um, I can segregate this whole work process into three different parts. First part being using this or masking these DICOM images and generating a regions of interest within this 2D images once, and the second part being using these generated regions of interests into a CAD model where you can plan, design, or tweak around before even printing or make it ready for printing. And once you have the CAD model, the third part's going to be 3D printing and post-processing it and performing the quality control and quality assurance on these models. So let me dig deep into these steps. So here's the, in this image, you can see the masks on the step one, and here's the CAD model in the step two. And this CAD model was used to 3D print, and that's on the step three, you can see a 3D printed and post-processed CAD model. So deeper into the segmentation process, once we have this 2D images, we segment out regions of interest. So here in this image, in the middle image, you can see that um, all the different ROIs, all the different anatomies have been color coded, have been masked with different colors. So here, purple representing the bone, red for the tumor, green for the esophagus, and black for the trachea. So once you have these 3D masks, the next step's going to be once all that is done, we review with a radiologist or we review with a physician asking, hey, is this the type of model you need, or do you need any changes to the model? Is this part a tumor or is it some other organ? So once we do the review, the next step is we make the CAD model. So here's a small video showing me doing the segmentation using a CT images. The first part of the segmentation is importing the CT images. So I'm here using Materialize Mimics 510K cleared software where I'm importing all these CT images. So here, once all these CT images are imported into the software, I segment out using thresholding. So where I dictate the images, hey, use only these range of Hounsfield units for me to separate out bone from the surrounding skin or muscle tissue. So here, once I do the thresholding, that's the ankle, whole ankle, that's what I get. And I want here to only segment out the calcaneus bone, and I'm here trying to split the mask into just calcaneus and rest all. So I'm selecting, hey, I'm telling the algorithm, hey, this is the calcaneus bone, and all these are background or some other bones which I'm not interested in. So once I tell that to the software, it does the volume calculations across all the imaging sequences, and then it only segments out me, or it only separates out the calcaneus bone here. And then I verify if there are any other bones that has been attached. So once that's done, and the next step is it is only in the mask phase, and I'm now converting this 3D mask into a CAD model, or giving it a solid shape to the model. So the software helps me converting into a solid model. And once you have the solid model, we do all process like smoothing, hollowing, whatever it is necessary to make the model 3D print, or whatever surgeon needs to have to see in this model. And once that's done, this will be ready for the 3D printing. When it comes to the 3D printing, when you have the CAD model ready, your job is to assign what type of material this 3D printer needs to have, or you need to dictate, hey, I want you to 3D print, or I want you to make this type of model with this particular material and with this particular color. So engineers dictate what type of material, what type of sureness you need to add to the model, how what orientation the model needs to be printed, and sends to the CAM software, and CAM dictates the same to the 3D printer. And this is how the model looks like once it is on the 3D printer. It doesn't look like what the end product model looks like, because the 3D printer doesn't have the ability to just print on the space. So it always prints on the platform. And when it is printing something on the space, it just lays all the support, and then on top of the support, it starts printing the model. So once the model is out of straight on the 3D printer, so that's how it looks like. And once you remove all the supports, either through manually or through the chemical process, that's how the model looks like. Often we 3D print multiple organs, and when you assemble the model, that's how the model looks like. Once all this model is done, we make sure the model is printed appropriately. It's of live size, and we take the dimensions, and we do quality check by measuring the angles, distances, depth, in fact, a diameter of this iota. So we do all sorts of this quality check and compare these with the DICOM images which we have used to generate these CAD models. Or we will be delivering this model to the surgeons only when it is at least 99.9% accurate. So I want to talk more about importance of imaging here. By now you can tell for a 3D printing to be successful, the beginning or the first step is the imaging. So I am only as good as the images are. If you want me to 3D print an elephant with such intricate structure as seen in the image, you can look at the surface texture on the skin. Everything is very high detail. And if you want me to 3D print this, I can 3D print this too. So very blocky, pixelated, low poly image. So it totally boils down to what type of image I'm using for 3D printing an object. So if it is a high resolution, high detail image, it ends up getting a high, very well looking, very detailed model. But if the images are very bad, poor resolution, you will end up getting a pixelated or blocky Lego looking model. Here's the another example. In the image A, you can see that there are no intervertebral disc spaces here. And also, if you can look at the extremities of these ribs, they are all blocky, pixelated, and they are steppered. But here in the image B, you can see there's a clear demarcation for these intervertebral discs. The ribs are very smooth and sharp. That's how they're supposed to be. So the difference between between these two CAD models are, one is generated, especially the image A is generated from a 2.5 millimeter thick CT images, whereas image B was generated using 1.25 millimeter thick images. So the resolution really, really matters with the 3D printing. The higher the resolution, best will be the 3D printed model. But again, it's not the case for every time. As the resolution of the images increases, the noise increases, and noise gives a lot of artifacts in the 3D printer too. So there needs to be a fine balance between the resolution of the images and the type of 3D model which you are expecting to have. For the purpose of 3D printing, we use both CT and MR images. So only there are few cases we got away with only using either MR image or either CT image. And the reason being, since we all know these two images are very complementary and both the images captures different types of data. So here, these are CT and MR images of a 63-year-old male who was presented with a thoracic spine chordoma. Here in the MR images, you can clearly see the extent of the tumor within the intervertebral discs and within the vertebrae, as well as in the spinal cord, whereas in the CT images, it just casts a shadow. So for me, if I choose MR images, I can clearly threshold and segment out the tumor and the spinal cord. But for me to segment out the bones, it would be a struggle with the MR images. There's only casting shadow. There's no way I can segment out the entire bony aspects using the MR. So I end up using CT images to also segment bony components. So I use both CT and MR images. The biggest problem when I'm using both the images is their registration. So here in this video, you can see all the bones have been segmented from the CT images, whereas the renal tumor and the kidney, as well as the aortic artery, renal artery, everything where all the soft tissues were segmented from the MR images. But you can see that the kidney was somewhere in the space, not in the particular location. So for us to have exactly registered or exact located images, we do the step process called registration. So once the registration is done, here you're looking at after the registration. So after the registration is done, all the anatomies fall in place. There are challenge. So these registration and using multiple images help with improving the segmentation accuracy, and also they give you a lot of detail when compared to only using one type of imaging sequence. The software which I have previously mentioned, has both automatic, semi-automatic, and manual types of registration here. So here's a small video of me doing a registration on T2 and T1 MR images of a brain using a 3D slicer free software. So here you can see both 2D, both T1 and T2 MR images, they are not aligned. They're just randomly overlaid on top of each other. And here I'm asking the software to, hey, could you overlay image T1 image on top of T2 image? And I'm asking it to do use all 6 degrees of freedom, twist it, turn it, relocate it both in X, Y, Z axis. And then when I hit it to apply all these setting changes, the algorithm automatically tries to register. And here's the registered image. Both T1 and T2 are well registered. So when I scroll through that bar, you can see both T1 and T2 images. If for some reason the images are low resolution and there's no enough contrast, and the automatic registration fails, you still have an option of manual registering both the images. So here's a video of me doing the manual registration. So it works the same way. It has all degrees of freedom. I can move, I can overlay one image on top of another image. I've chosen T2 image to be overlaid on top of T1, and I am moving the bars left to right, anterior to posterior, inferior to superior, as well as I can also do the rotation both in the left to right rotation, anterior posterior rotation. So whichever I am very satisfied, I can move the images and overlay on top of each other until I am very satisfied. So these are the two type of 3D printing, 3D registering techniques of these 2D images. It's not always butterflies and rainbows. So sometimes the images are too bad. They are highly, very low resolution, and the automatic registration fails. Below are some of the challenges I always face when trying to registration. So here are the CT and MR images, both A and B, of a 64-year-old female who presented with a left chest wall sarcoma. And I was trying to register uh, MR images on top of the CT images so that I can have the whole rib cage and the aortic arch, everything segmented from the CT images and the tumor segmented from the MR image, but the registration failed. So here's a video showing the failure of the registration. So as you can see, they are not aligned appropriately. And the reason being, CT images were acquired with patient arms position right above the head, and MR images were acquired with patient having their arms in the normal location. Right here, you can see in the CT images, the patient arms are right above her head, and patient arms in the CT images are usual. And here's another case. So these are images of a 27-year-old male who presented with a synovial sarcoma right near the C7 and T1 level. I have to use, you can clearly see that the bone is very pronounced in the CT images and the tumor is very pronounced in the MR images. But when I'm trying to do the registration fails because of the patient position. As you can clearly see here, the patient's spine in the CT images is very inclined, very sharp, and very straight. But in the MR images, the patient position is arched, curved, and it's not a straight line. That's because they used a cushion to put it underneath the neck when acquiring the MR images, but no cushion was used in the CT images. So especially when working with these cases, it's really hard for me to register both CT and MR images. And when there is no registration, it's hard for me to get the full extent of the disease segmented and have a 3D printed model. Here's another example. Not just the patient position or type of image acquisition that are the issue, even dynamic tissues are issue here too. So here, these are the images of a patient presented with bony sarcoma on the left side hemithoracic. And here you can see that one of the imaging sequence, it was acquired with patient being in the inspiration phase, and the another imaging sequence acquired with patient being in the expiration phase. So here you can completely see that the diaphragm is moved, pushed superiorly all the way, and the lung one has been compressed and one has been relaxed. So it's tough for me to register the tumor in that location. So here in this image, you can clearly see right at the sternum, the differences in the sternum between both the images. In addition to the patient positioning and having a dynamic tissue, like I mentioned before, image quality also plays a huge role. Lack of sufficient contrast would not allow me to produce a great looking 3D printed models, or at least the models with high details. Image scattering, even having a highest resolution, say 0.25 or zero point 0.5 resolution, there are chances that it introduces noise. And when there is a lot of noise, the 3D printed model doesn't look very smooth, neat, and easy. It all looks very bumpy, very rough. Again, when there are implants or metallic artifacts within the body, there's a lot of image scattering, and even with that image scattering, it's tough to segment out the regions of interest and eventually produce a 3D printed model. Again, minor problem with 3D printing here using CT and MR images is the data sets we use. Sometimes we use multiple images from different time points. Say I'm using a year-old CT image and 2 years old MR image and current CT and MR image. When I'm merging all these 4 or 5, crunching together 5 different data sets, so it's a big data set I'm talking about, each having 1 mm slice, 500 images in each imaging sequences. So I'm talking about 5 to 6 GB of all this data. When I'm trying to crunch here, usually it ends up failing the software or errors with the software and just not performing the registration. Some of the potential solutions for these problems are cropping the images tightly to the ROIs. So if you remember in my previous slides, I've shown this image where the registration was very tough, and here you can see the sternum is in different location. But when I do the registration on the same images, except for these images have been tightly cropped to the region of interest. Here, the tumor is right next to the sternum, and I do not care how the spine is, neither the physician cares how the spine is. We are only interested in the sternum and its tumor right next to the tumor. So when I crop the images very tightly right near the tumor and the sternum zone, in the image B, you can see how well they both are aligned and how well they both are registered. So once we have this such a nice registration, it will be easy for me to segment out tumor from both MR and CT and have a full spectrum of the tumor. Another solution is splitting the regions of interest. So here you can see the CT and MR images of a 68-year-old male who has been presented with a chondrosarcoma of the bone right near the pelvis zone. And here's the registration of both CT and MR images. As you can see, they are not aligned right near the arrow marks, especially near the iliac crest and the femoral head, because of the patient position and lying in 2 different positions. To fix this, what we can do is split the complete mass. So here in image A, you can see the whole pelvis as created as one CAD model. So to alternatively, if I can make multiple CAD models of each individual bone, here in the image B, you can see the sacrum has been segmented separately, both right and left iliums segmented separately, and then femurs on both right and left segmented separately. Once you have these models segmented separately, you can align them each bone separately, and you can have a perfect alignment. So here in the image A and image B, you can see the bones misaligned with respect to the CT, with respect to the MR images. But once all the bones have been separately segregated and then aligned manually, here in the image C, you can see that all the bones are well aligned and they are properly in the exact location. So those are some of the challenges related to the images that we use for 3D printing. Other than the imaging challenges, we also always have challenges of availability of the materials. There are only limited types of materials that we can 3D print as of today, and speed of the machine. For me to make a CAD model, I'm trying to show you a 3D model. So for me to 3D print a model, something like this, um, I'm still trying to go back so that I can show you a 3D model. Yeah, for me to 3D print this model, it took me 3 days, 5 hours just to print it on the machine. And 3D print, and before even I start the 3D printing on the machine, it took me at least 1 or 2 days to segment out regions of interest and get it validated with a radiologist as well as a surgeon. So it would take a huge time. This took at least 3.5 days to print it. So it's going to take a lot of time. Speed of the machine is still an issue here. So that's the reason we cannot use this 3D printing in an emergency case situations. In addition to the 3D printing accuracy of the machine, so it's an utmost importance. You need to always know if the machine is printing the exact or object or exact CAD model that you have been requested. Say if I ask the machine to print 1 centimeter by 1 centimeter cube, is it printing 0.9 centimeter by 0.9 centimeter, or is it printing 1.1 centimeter by 1.9 centimeter? So it needs to be very accurate as what you are defining it to print. So quality check and quality control is of utmost importance, especially in the healthcare field. Um, so these are some of the current challenges with the 3D printing, and with continuous development and R&D, most of these challenges, they are trying to suffice, but we are not there yet where we have an ideal solution for all these challenges. Thank you. I'm up for any questions.
Thank you very much, Dr. Tappa. Excellent talk, very insightful, and I learned a lot during this talk. And I'm
Thank you.
on the podium for questions and discussion. So we have a question in the chat by Dr. Halkar,
Mhm,
a nuclear physician at MD. He's
mhm,
one of the senior professors at MD.
mhm,
So he said those who practice nuclear medicine before cross-sectional imaging like CT use lots of imagination and assumptions. Cross-sectional imaging, 3D rendition like MIP, surface rendering, and 3D modeling have allowed elimination of assumptions
mhm.
for the evidence-based interpretation and intervention.
So
So
I'm glad. I'm glad.
Yeah, this is Amol. Nice talk,
Hey.
Karthik. Excellent, images and a good overview of these things. Something that we don't get, exposed to during our normal day-to-day life. But as Dr. Halkar mentions, that 3D renditions have helped us, and you keep on
Mhm,
saying, 2D images.
mhm.
Realistically, if they were just 2D images like X-rays or planar images, you really
Mhm.
can't use those to make
Totally.
a 3D. It has to be a tomographic image
Yeah,
that can be done into a 3D rendition, various reformats and all that. And that's what you use for 3D printing. So
absolutely.
my question is, instead of printing
Mhm.
something, the issue is, projecting these 3D images on a 2D monitor or a screen surface.
Right.
And I understand patients can't relate to it. They don't understand what the heck what you're pointing
Yeah.
to, especially if
Yeah.
it's a black and white grayscale image of a CT cross section. They have no
Right.
clue, and they have to trust you or believe you or whatever.
Of
So
course.
what if we project those as holographic images in a 3D space and use that for patient education rather than spending all this time and effort to actually model and print and show it as a touch and feel to the patient for patient education.
Totally. I totally agree what you said. So that's where AR, VR come in. And again, even with using AR, VR, you still need to segment out these 2D images and have somebody tell, hey, this is tumor, this is not tumor, especially when I'm talking about tumor. If it is a regular anatomy, algorithms can still go ahead and do complete segmentation. They'll segregate, hey, these are bones, these are arteries. But when it comes to the tumor, only a trained eye, only a radiologist can depict, hey, this part is tumor, this is not. So we still needs to do the segmentation, and we still needs to develop the CAD processing. So once you have the CAD, you can either use it in the 3D space, like you were
Mm-hmm.
mentioning, either in the AR, VR, or you can send this to the 3D printed model. But again, in 2022, Dr. Nicole Wake did the same study, comparing comparing renal tumor patients, splitting them into two different cohorts. One cohort were only shown, put on a HoloLens or a Google Glasses, and they were shown their pathology, or they were shown their anatomy. Hey, this is where the tumor is. And there was another cohort where they were handed out a 3D printed model. I was very surprised. I was thinking the same. Oh, instead of us going, wasting the material, waiting for 3 to 4 days, post-processing my manual labor and producing a model, I think this is way better. But one thing they lack is haptic. The one thing they lack is the feedback. So when you have a handheld model, let me see if I can share this publication with you, or within the chat. So it's a very nice publication, and the results of that publication is the patients or the surgeons, they feel like having a 3D model is way more useful than then putting the goggles and then putting the headset AR, VR, spinning the CAD model, simultaneously viewing the images. So that was the result of it. But again, some of the other things that we need to consider is patients are not really tech savvy. This is a new arena, so they can just hold the object. That's the ease with the 3D printing, and with the AR VR, it's all new. It's tough for them to twist, rotate, turn. So probably that might be it too. But again, I myself see the future as having it in the AR VR rather than having it in the 3D printing.
So let
Yeah, I
me
mean,
let me chime in here,
Yeah.
Sure.
Amol.
Yeah.
One of the reason is we as human beings have lived in 3D world,
Yeah,
and our total conception of any image or anything we experience is not
mhm,
only by eyesight, by also by touching.
I agree. Totally.
So unless we train our children or the younger generation to be always be in the virtual world, then what you are suggesting would work. For those of us who grew up in a touchy feely world, um, and an object, a 3D object will be always be more applicable or palatable than a 3D virtual image. Dr. Garcia always used to say that, you know, all our evolution has taken place in a 3D world. Even though the image on our eyes retina is a 2D image, our brain has developed an excellent capacity to conceptualize the 3D concept of the real world. It's more of a neuroscience aspect, more than the imaging aspect. Before I leave, I want to tell one thing about the initial, very good lecture, and I enjoyed it.
Thank you.
The first slides which you showed about manufacturing.
Mhm.
You see, in India, Shilpa, where statues were made in all the temples,
Yeah.
were destructive construction. They
Yeah.
chiseled off things.
Yeah.
But in India, we did Ganapati, Ganesh, in
Right.
mold, in a
Oh,
mold,
yeah.
in a
Yeah.
cast. So
Yeah.
we did we did a 3D modeling at that time without
Right.
destroying anything. We used
Right.
sort of a soft soil.
Right.
So
Right.
when it comes to construction, the aim of the construction, if you are doing a construction that would last for centuries, destructive construction with a solid material is better. If you are disposing of a statue after 7 days, doing something like a um, modeling is good, and you can destroy it and next year you make it again.
Yeah.
Now, even in car manufacturing, previously cars were made to last for 20 years, 30 years. Now cars are made to last 5, 6 years. Houses are
Right.
not made to last long also. So we are more into Lego kind of construction work, not solid wood, compressed wood, or things like that. So generationally, we have changed our concept whether a particular item should last long, or particular item, I want to renew it every 10 years or 5 years. Uh, then the construction concept changes. and destructive construction is no more like, because we are in a temporary phase. Everything is transient. We don't want the same house to last 100 years. We want every 30 years new technology in the house and things like that.
Got it.
So that's the difference. Each has its own advantage and disadvantage.
Totally.
Depends on what you're looking for. Okay,
Yeah.
thank you.
Thank
Interesting
you.
philosophy, Dr. Halkar, and I agree that the old farts like us are actually more into the touchy-feely things. But I mean, the society as such is moving. Like if you look at Mark Zuckerberg's vision, everything is going to. I mean, even our money is all virtual. We hardly touch and feel the dollar bills or the rupees anymore, right? It's all
Yeah,
transactions.
Bitcoin now. Yeah.
So the
Yeah.
issue I think about that paper, I would be interested in seeing that paper, and I want to
Yeah, I've
see
sent you the paper. I've sent the link in the chat.
if it's the surgeons who feel that the 3D printing was better, or even the patients, because the patients are
Patients.
not going to operate, right? So I
Yeah.
would be curious why they felt that and unless like those are 50, 60, 70-year-old patients versus the younger generation, the study if
Right.
repeated might be
Right.
different. But there are this is a very interesting topic, and it's being used in medicine. My second question was about reimbursement, for say for patient education. Surgeons are already pressed for time.
Hmm.
They have to operate and do more surgeries for lesser reimbursement, and then presenting all this, has it shown to decrease their time to explain the complicated surgery to the patients with more patient buy-in, or is it something that gets added on? And so because I don't know if this is reimbursed by insurances. And so for I don't know how MD Anderson is sustaining it. There are rich patients who come to MD Anderson who may pay more, but for a regular center, how do you make this sustainable if reimbursement an issue? And so any thoughts on that?
I am so glad that you asked about this. So in the year September 2019, AMA has released three category 3 CPT codes: 0599, 0560T, 0561T, and 0562T. So not three, four, all four codes pertains to the 3D printing model. The first two codes, 0599, 05960T, both related to the anatomical models, and the next consecutive two relates to the 3D printed guides. So once we do the services, we bill patient insurance, not the patient, not the physician. That's how MD Anderson is sustaining.
Awesome. And so is it the surgeon, or is it the hospital, or the biomedical engineering who's billing the insurance company?
So these are category 3 codes, and these are only technical codes. So me as an engineer, I bill them, not the surgeon. I mean, I'm still gonna need authorizations, and I'm still gonna need surgeons to dictate the need for the 3D printing models. And once that's done, I'm the one who'll be dropping the charges. I'm the one who'll be billing for these models.
And do you have any guesstimate about what the reimbursement is like in dollar amounts?
So it totally boils down to the type of material, type of technology you're using. So since I'm mentioning multiple different types, I don't use one single material one single time. So they range all the way from $40 to tens of thousands of dollars, depending on the complexity, how many organs you're 3D printing, how big of a organs, or how many iterations that you're printing. So it all, there's no hard and fast rule. Hey, here's $1,000 model. So if I'm using a fixed fused deposition modeling and I'm printing a complete rib cage, the material cost is going to be about $40. The big 1 kilogram spool is about $40. So
Yeah.
if I'm using a PolyJet machine, which is a $560,000 machine, and one cartridge is about $1,200 cost, if I'm printing the rib cage, it prints with the materials as well as the support, it's going to be about $2,500 to $3,000. So there's no one particular number that I can give you, but I can give you a range. It varies a lot.
And how does that translate to the efforts and your own cost to sustain this service? Is it sustainable, or is it a net loss to MD Anderson and more of a marketing thing that we do this and it's better care at MD Anderson?
So MD Anderson, we are focused on patient outcomes rather than budget here, rather than the money here. So
That,
I'm very glad that MD Anderson is doing that. So MD Anderson understands that the 3D printing brings in the value, the 3D printing brings in the better patient outcomes, and that's the reason it's always supports me. I'm not saying we are not self-sustained. Yes, we are self-sustained. The only issue right now we have is these codes are only technical codes. That means only my effort and my work has been paid, but not. So I'm sitting with a surgeon, I'm sitting with a radiologist to review these tumor segmentations, to review this masks. So we are not getting paid for those.
yeah, right.
Yeah, that we are not getting paid, but we are still getting paid for the technologies. But in turn, if you think like that, if the same surgery without a 3D model, it's going to take, especially Dr. Arave Porcian, he's the head for the cardiothoracic surgery. So one of the images that I've shown where there was a tumor right next to the sternum, in his own words, he said, without 3D printing, it would take him around 6 to 8 hours in the OR to take whole tumor out, and once the tumor is out, everything is collapses and he retracts everything, places the plates and everything. But but the same surgery when he's doing with a 3D printed model, he pre-bends the plates using a 3D printed model. He'll have a template, he'll know exactly where to land a screw, where to put the where to put the plate, and once the tumor is out, all he does is plug and play, just takes the plates and play. So he cuts from 6 to 8 hours surgery to 3 to 4 hours surgery. It's a half time. So he can spend the rest half looking at other patient, taking care of other patients. So there's a value in that. That's how the surgeons see here in MD Anderson.
So basically, it's increasing their productivity by doing more
Exactly.
more clinical cases
Yes.
at that basis.
Yes. Yes.
And on the same lines, instead of in addition to patient education, I think this 3D printing model could serve as a good tool for education of residents and fellows and nurses,
Totally.
PAs, and
Totally.
other staff and all that. Just as
Totally.
it's actually helping the surgeon plan it faster and get better, it's going to help all these other people
Exactly.
learn better as well. And that cost, I think, could be reimbursed, because these could come from these could be charged courses that, hey, you'll get, and you can reimburse costs from that and make the service more sustainable as well, actually. So
Totally.
that's something that can be done as well. But going back to the outcomes, is there any data that shows that surgeries done with 3D printing models have they're faster, but
Yeah. Yeah.
are the outcomes better compared to non 3D printing models?
Sure. So there are a couple of publications which talk about reimbursement alone. There are a couple of publications which talks about outcomes like blood loss, OR time, the amount of fluoroscopy time. So there are publications, I can find them up, but you can look them up too. So there are tons of publication, and me myself, along with my colleagues here, we are still in the process of collecting the data. We've been collecting it for 4 or 5 years now. We are still the data is still with the biostatistician, and once that's done, we'll have a publication on our own, the reimbursement as an MD Anderson perspective.
Yeah. And so you did comment on some of your limitations and challenges. And I was curious, these days, misregistration, we've been in nuclear medicine and hybrid imaging. We've been dealing with that since the beginning of hybrid imaging, when we started fusing PET and CT or SPECT and CT, and even sometimes with PET and MR and so on and so forth. So we are very familiar with the misregistration challenges, and there are various ways to get around it, and you can reformat and warp and do whatnot to make the images fit, because we also try to compare it to normal databases that may be in a different shape and format and so on and so forth. But it's very difficult to get around artifacts. Like there can be artifacts of different kinds, metal artifacts, beam hardening artifacts, dense contrast artifact, whatnot. And sometimes patients can't get a study because of metal or something like that. So how do you deal with these things with your 3D printing modeling?
Oh, it's very tough to deal with these things. I'll be honest with you. Um, the software which I keep talking about, they do have an ability to reduce the noise, reduce the scatter. They have algorithms, but honestly, they are not that great. Most of the times, I end up doing it manually and then reviewing it with the radiologist or the surgeon. So that's a huge limitation, I would say. There's for us at this point of time, there is nothing that I can think of that can overcome this.
Yeah, there are, at least in the CT world, they have tried image reprocessing algorithms that can remove the artifact from metal, and it's being validated pretty well. So I was just curious if you guys have started using that in your 3D printing models to when you generate the draft. But anyway, that's just for food for thought. Last question before I don't want to hog. There are some more questions in the chat, but
Sure.
one of the issues is when you said about the end block resection of the entire tumor, the limitation is in our perspective, there's no imaging modality that's going to tell you disease at a molecular or a microscopic level.
No.
And with molecular imaging with specific probes, with PET, we're trying to push that boundaries, but it's nowhere near microscopic thing. And so there's always going to be things that they're going to find during the surgery, and so I would be a little bit cautious when relying solely on that model because you have to. I mean, that's why even with radiation treatment planning or when you're planning a surgical resection, you put some boundaries and you put a collar around it and all that. Do you when you're making that model for resection, do you take that into consideration as well?
Well, we are true to the pixel. That's the sentence I always use. So I sometimes do pixel picking. If that pixel has different Hounsfield unit, or if it is lit differently than compared to the next pixel or the pixel after that, I'm going to choose that as a tumor and then review with, of course, radiologists. So once I have that, our surgeons here, they always draw margins like you were mentioning. So if it is a cardiothoracic, they do at least 2 centimeters away from the tumor, surrounding tumor. Okay. So we draw a 2 centimeter margin across the tumor, and then that's where they start their resection. So the pelvis, I don't think they can give 2 centimeters, especially when the tumor is right near the sacral region. That's where they want to be really stingy and save as many nerve roots as possible, having as much give them mechanical strength as possible. So they usually sometimes go 1 centimeter. I've seen patients, surgeons who has gone 0.5 centimeter, not 0.5 centimeter, 5 millimeter. So it totally depends on the location of the tumor, but still they do give boundaries.
Awesome. So you're a true biomedical engineer. You're actually a liaison between the engineering and the clinical people.
Yes.
So
well said.
In spirit and word, and amazing. I mean, I'm very glad that you're doing this. A request to Jigasa or Saima, can we capture these links in the chat and have them emailed to us?
The links, you mean that?
Saima, I can send them to you, Saima.
Yeah,
don't struggle.
It's kind of hard to grab them on your mobile device, or I'm on my iPad, so it's hard to get it. So if somebody Saima, go ahead and there's a few other questions.
I have a couple of questions.
Sure.
Jyotsna here.
Sure.
Excellent talk. I learned so much.
Thank you.
Basically, what does the future hold? Like, what are people working on right now? And the other thing is, can this be used in medical education for anatomy and all that? And the third question is, have you matched the surgical margins with the pathologist's margins, like when they do the final histopathology report?
Yes, coming to your first question, I responded to you in your chat, but again, I'm going to tell you. So what I see, I've been here doing this 3D printing and stuff for the past 14 years or at least 13 years now. And the trends that have been shifting now are from initially started with 3D printing, and now it's slowly moving towards AR, VR. And now from AR, VR, I think the next step gonna be tissue, biomedical tissue, and organ regeneration. So that's where we will be ending up, rather than just printing a 3D printed plastic model in future, maybe a decade from now or 15 years from now. I wanted to see this 3D printing, and I think the 3D printing will be 3D printing tissues, organs, because there's huge scarcity of the organ donors currently in the market, and years of waiting time for all these donor receivable patients. So I think that's where the most focus is going on, most research is going on. There is this one particular publication from Chicago University where the researchers have 3D printed rat ovary scaffolds, and they have implanted the rat ovary scaffolds into the mice or rat. I'm confusing. So into the rodent, and to the surprise, the rodent even bore pups. So that's the extent of 3D printing at this point of time. I can find that article, and Saima, I can send it to you so that you can share it to the group. So that's where I see the 3D printing in the future. Um, I'm sorry, what was your second question?
Medical education.
Yes, we still do medical education with these 3D models, and there are some procedures which are really painful, and it's tough for fellows or residents to learn directly on the patients. The one procedure that I can think of is tandem ovoids. I personally worked with our gynoncs where we developed pelvic ultrasoundable CT or MR scannable models from the patient data. So I took the patient data from one of our gynonc patient, and then developed a model having ovaries, uterus, rectum, vaginal cavities, ureters, and everything very close to how the model will be when you see it in the CT and MR images. And residents and fellows have practiced tandem and ovoid in that model. So it was invaluable for them, and it's always safe for the patients rather than them trying on the patients. It's always good they try on these models first and get used to before they even go to the patient. And what was your third question?
Third was, did you match the surgical margins with the pathologist margins?
Sure.
Like,
All the time. So once the tumor is resected, the next door is the pathology room. We send the tumor to the pathology room, and when they start stitching up together, or when they start doing the reconstruction, we wait till we get a call from the pathology department that the margins are negative. Only then we'll start doing the resections. So yes, so we take images of the once we hear that the margins are negative, and only then we'll sometimes take images, compare these images with the 3D printed model as well as the DICOM images. We'll compare and contrast just so that we are double sure. So we do compare everything. Yes.
okay, so you get cleaner margins, I
Most of
assume.
the time. Yes, most of the time. I haven't, so we do like 60 to 80 a year, and well, as far as I'm in the OR, at least for 50 of them, I'm not in the OR. It's just the surgeons doing it because they are used to these models by now. So if I'm in the OR, I wait and check. So there was never a case where we had a positive margin.
Oh, very good.
Yeah.
All right. So I think excellent talk. Dr. Tappa, if you can send me those links, I should
Of course.
the ISNM.
Of course. Thank you all so much for having me and giving me this opportunity.
Sounds good. Thank you.
Alrighty. Yeah. Bye.
Take care. Bye.